7, 6, 5, 4, 3, 2, 1.
You'll never have the sacred stone.
Oh, this you crazy mother.
Farsalinos and Dr. Delon, welcome. Welcome to South Africa. Dr. F,
Thank you.
Is this the first time that you visited South Africa?
No, I've been here before.
Okay, and I think what everybody would like to know is also just the specialization. So specialization, doctorate, and affiliations.
Yeah, I'm a cardiologist by training, but I'm doing full-time research on tobacco harm reduction. And I'm affiliated as a research fellow in 3 institutes in Greece. At the Onassis Cardiac Surgery Center, which is a hospital, we do some clinical work. At the University of Patras, the Department of Pharmacy, when we do a lot of laboratory work. And at the National School of Public Health in Greece, where we do mainly population studies or some clinical stuff on smoking and e-cigarettes.
I'm Delon. I'm a specialist family physician and qualification in child health, and former Secretary General of the World Medical Association and of the International Food and Beverage Alliance, and currently of the Africa Harm Reduction Alliance.
Okay. And then I think everybody wants to know is, do one of you guys vape?
I vape because I was a smoker in the past and I have tried and failed repeatedly to quit with all available smoking cessation medications. So after I analyzed the results of my first study in early 2012, I decided to give a cigarette a try. I managed to quit on day 1 and I'm smoke-free for the last 6.5 years.
I don't vape myself, but I have a suitcase of vaping products from different companies. And each of the family, my family, they know that if they smoke, then they become a target. And I try and convert them, I encourage them to switch from cigarettes to vaping products.
Perfect. And then at what point did, Dr. F, did you move from being a skeptic to being an advocate?
To be honest, initially I was not just a skeptic, but I thought it was a useless product for smokers. And the whole experience of research started from 2 friends who were smokers and started using an e-cigarette. And that's what triggered me to start doing some research on it. So when I started that, I was very skeptical. I thought it's a useless product. It's not going to help anyone quit. But I did a clinical study that invited a lot of e-cigarette users from Greece, and I learned a lot from them. And when I started seeing the results of my research, which was mainly a comparison between use of e-cigarettes and use of tobacco cigarettes, then I started realizing that there is a potential. And I started doing research more intensively and on a larger scale in all aspects of research. I started mainly with safety issues, comparing e-cigarettes with tobacco cigarettes. But then I moved on to also population studies, analysis, regulatory issues, so covering basically all the aspects in the research field on electronic cigarettes.
In my case, that's a great question, by the way. In my case, I was an active clinician in South Africa. I built up 3 practices with each about 5,000 to 6,000 families, and helped build an emergency ward at a hospital in Pretoria, and was active in the public sector. And I was what you would classically call a traditional tobacco control doctor. I was telling patients that they should quit or they will have die an early death. Very, very bad approach to be an empathetic physician to your patients. And my turning point came with my father. My father was a smoker of about 60 cigarettes a day and developed larynx cancer. And I realized that it was extremely difficult for him to stop smoking. And I then read the results of Swedish snus, where in Sweden, instead of the average 20% of the population who smoke cigarettes, In many cases of many areas of Sweden, less than 5% smoke, but they use snus, which is a little pouch with tobacco which has been pasteurized, and they have much lower smoking rates, and in comparison to all the other EU countries, they have much lower rates of heart disease, lung disease, cancer. And then I realized that I was not respecting the data and the evidence, and that was my hallelujah moment, where I realized that tobacco harm reduction products, in the past something like snus and even today, and now vaping products, offer a way out, it's a gateway out of smoking. And that I was being irresponsible not to tell my family, my father, patients.
Okay, so my doctor is of the opinion that vaping is smoking and smoking is vaping. It's the same thing. So do you feel that doctors are following the latest research in vaping or e-cigarettes?
If I can answer, if doctors are advising patients that smoking is the same as vaping, I think that they should carefully research the current evidence and rather not say anything to their patients if they are not sure of their knowledge. It is our ethical duty to provide accurate, evidence-based information to our patients. And frankly, there is absolutely no comparison in terms of smoking and vaping, except that it's both an oral inhalation of a product. But in terms of the harm caused by combustible cigarettes is not comparable to what's happening with vaping. We all say that there's clear evidence that at least it's 95% less harmful, but for us who work with this professionally, I'd say it's closer to 99%. Vaping is not safe in itself, but in comparison to the ongoing smoking of combustible cigarettes, it is significantly less harmful.
Healthcare professionals have the scientific, professional, ethical, and legal responsibility to provide accurate information to the patients, and in that case to the smokers, to the best of their knowledge. And if they don't have enough knowledge, they should look for it. In the same way that they're responsible for benefits achieved to patients when they treat them successfully, they are also responsible for false decisions that a patient makes when they influence these decisions. And a statement or an argument that the e-cigarette is similar to smoking and there's no difference is not only wrong, but it's also actively discouraging the smoker to try this product in an effort to quit, and this directly causes harm to the health of the smoker. And it's not an informed decision by the smoker, because it is based on misinformation. So physicians, who I'm sure fully understand their role and their responsibilities, should be very careful when they provide advice to smokers about smoking, because any decisions made by smokers are life-changing in terms of their risk. So it should be taken into consideration very, very carefully and fully supported with evidence-based, whatever they are willing or trying to say to the patient.
Maybe just on that point on nicotine specifically, because nicotine is a misunderstood molecule. Nicotine, like caffeine and coffee or ethanol and alcohol, are psychoactive drugs. In other words, they have a psychoactive effect on the brain of consumers. But up to about 3 years ago, 70% of the physicians in North America thought that nicotine per se caused cancer. This is absolutely false. And even in South Africa, many physicians still believe that nicotine causes cancer. And it's really important for physicians who advocate for the health of their patients, make sure that they understand, that they read and understand the new evidence, and make sure that when they communicate health information on nicotine to patients, that it's done accurately. Nicotine is much like caffeine, it's a social drug. And if used in nicotine replacement therapy to stop smoking, or within vaping products, it is not as harmful at all as combustible cigarettes.
Absolutely. So With the flavor ban being in the spotlight now in the US, Dr. If you did a study in 2013 about the importance of flavor options. Can you tell us a little bit about that study?
Yeah, that study was done a few months before the European Union finalized their regulatory framework for e-cigarettes. And it was done exactly for that purpose. The EU was planning to ban flavors besides tobacco flavors, and that's why we did the study. It was the only evidence until then supporting the need for different flavors in an effort of a smoker to quit and switch to e-cigarettes. For the US, the FDA, in the announcement on the advanced notification for proposed regulation, they cited this study, but we didn't only present this study. We performed, and they have submitted officially as a comment to the FDA docket before the deadline. Now the deadline has passed, you cannot submit any comments. A new survey that we did in the US with more than 69,000 unique participants, presenting exactly the case of flavors and how flavors are used in the US population and what's their effect on the smoking status of the participants. And we managed to gather this data from a large, very large sample. It's the largest survey ever performed on e-cigarettes, 69,000 people. We did a preliminary statistical analysis, and we created, it's not basically a comment, it's a study that we submitted to the FDA, and very soon we are going to announce publicly the results of this study and what exactly we submitted to the FDA, because the FDA until now has not released it in public. They have thousands of comments, it might take time, but we have the ability to release it ourselves publicly.
Excellent. In the same year, we also did a study on the effects of electronic cigarettes on blood, oxygen in blood and blood pressure. Can you tell us a bit about that study?
Yes. These are clinical studies that are usually done. There are two types of clinical studies. There are the short-term effects studies, which means you evaluate what's happening before and after using a tobacco cigarette or any cigarette for a few minutes. But there are also the long-term studies that are done when you follow up people for a long time, for months. After switching to smoking, you compare them with smokers. Now, at that time, we didn't have any clinical data, so the acute studies were important to understand what is happening, although most of these acute effects are happening because of nicotine, and they are largely benign in terms of long-term prognosis. What we need to do now is move to longer-term follow-up studies, but that's going to take time in order to create the sample that you will follow up and then follow them up for several months or even years. So we expect that this is going to take time. But this doesn't mean that we should be overly restrictive or even apply bans because we don't have long-term epidemiological evidence. For every new product, even for new pharmaceutical products that are developed every day, you don't release them to the market after you obtain long-term epidemiological evidence because it's impossible. Imagine a company investing so much money in creating a new medication and then having to wait for 10, 20, or 30 years before marketing the product because we need long-term data before the product is available. This has never happened in the history of humanity for any product because it is impossible to happen. What we do is what we call post-marketing surveillance for medications, but also for anything else, which means that once we have, and for e-cigarettes we have a lot of data about their relative risk compared to smoking, you have the product in the market and you are following the people who are using it so that you are gathering data on the long-term effects. That's happening with everything. That's a reasonable approach, and that's not going to be an exception for e-cigarettes. These cigarettes are going to follow the same pattern as anything else, which is new and is now coming out in the market.
Thank you very much. The final question then is around heat not burn versus electronic cigarettes.
Yes.
So in terms of toxicity, what is the difference between them?
Well, about a month ago, we published a study when we compared aldehyde emissions from an e-cigarette, from a tobacco cigarette, and from a heated tobacco product. I usually call them heated tobacco products, not heat no burn. I think it's more accurate to call them heated tobacco products. What we found is exactly what we suspected, that the heated tobacco products are lower risk and release lower levels of toxic emissions than a tobacco cigarette, but the e-cigarette is even safer, is less harmful than the tobacco heated product too, so the level of toxic emissions from the e-cigarette are much lower than the heated tobacco product too. So there is what we call a risk continuum, with the tobacco cigarettes of course being the most harmful. Then there is a big gap between tobacco cigarettes and heated tobacco products, but there is also a gap between heated tobacco products and e-cigarettes. The e-cigarettes are the least harmful option you have now today from all the alternative nicotine-containing products.
Thank you very much, Dr. Farsalinos and Dr. Delon. Really
Thank you.
appreciate all your time.
Thank you. Thank you.